Good evening and welcome. Thank you so much for joining us tonight for the webinar, Stop Making That Noise, presented by Dr. Marla Deibler. My name is Katie Delaney. I am the Family and Medical Outreach Coordinator at the New Jersey Center for Tourette Syndrome. I will be your facilitator for this evening. Now, before I introduce Dr. Deibler, we have some housekeeping notes. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. If you have questions after tonight's session, you can post your questions on the Wednesday webinar blog, which can be accessed from our homepage at www.njcts.org underneath the heading Programs. This blog will be monitored for the next 7 days. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, and usefulness of the information presented on our site. We do not endorse any recommendations or opinions made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. With that being said, it is my pleasure to introduce our speaker for the evening, Dr. Marla Deibler. Dr. Deibler is a licensed clinical psychologist and the executive director of the Center for Emotional Health of Greater Philadelphia, specializing in the evidence-based treatment of anxiety disorders, OCD, and related disorders. Dr. Deibler serves on the Scientific Advisory Board of the TLC Foundation for Body-Focused Repetitive Behaviors and on the faculty of TLC's Professional Training Institute. She serves as president of the Board of Directors of OCDNJ and New Jersey affiliate of the International OCD Foundation. She is also a consultant for the New Jersey Center for Tourette Syndrome and Associated Disorders and visiting clinical supervisor at the Rutgers University Psychological Services Clinic. Dr. Deibler, we are so happy to have you here tonight. The floor is all yours.
Thank you so much for having me, Katie, and everyone else at NJCTS. Today, we're going to be talking about misophonia. So let me get my screen situated here. So this is what we're going to cover today. We're going to talk a little bit about what we know about misophonia in terms of our understanding of it to date. There's a lot more that we don't know than what we do know, but we'll talk about both of those things. We'll talk about our understanding about what it is, the impact that it has on individuals' functioning and other people in their lives. We'll talk about the neurobiology of hearing and of the understanding of the sensitivity to sound that individuals may have. We'll talk about where this comes from, the diagnosis of it and assessment of its symptoms, and we'll talk about the way that we conceptualize it behaviorally so that we can provide some treatment for it. So what exactly is misophonia? So misophonia was first characterized in the scientific literature, actually in the auditory literature in 2001. However, it doesn't actually have a diagnosis, not a formal diagnosis at this point. So how we typically diagnose it in terms of what you would see on paper or in a diagnostic code that you might see on a super bill from a doctor's office, for example, is other obsessive compulsive and related disorder. And we'll talk about later why we describe it that way. There is no formal diagnostic code right now for misophonia because we have yet to really determine the diagnostic criteria that should be in place that really describes the set of observed symptoms that we see in this population. The research on misophonia is really still in its infancy. We're still really learning a whole lot about it. So it was initially described as a form of sound intolerance in which there was a hyper-responsivity of avoidance behaviors and other sorts of externalizing behaviors to a particular sound. So the term misophonia is derived from Greek, miso meaning hate and phone meaning voice. But it actually involves more than that, and we'll talk about how that's evolved over time. Misophonia typically onsets in childhood, and it's characterized by the experience of an unusually intense and immediate response to specific stimuli, typically auditory, although it could be visual stimuli or kinesthetic stimuli as well. And we'll give some examples of that later on and how that has generalized. But in terms of the reaction, there is an intense emotional reaction to the stimuli. So that can include things from emotions from irritation to anger to rage to discomfort in general to anxiety or disgust. In general, individuals' emotional reactions to the triggers is a sense of feeling immediately overwhelmed in an intense way. Those individuals don't want to feel that way, and they recognize that the response that they're having is excessive and that it's usually socially unacceptable or inappropriate to the context, but they often also feel as though the behavioral responses are uncontrollable to some extent. So in addition to the emotional reaction, there's also a physiological reaction. So the autonomic nervous system gets activated in ways that it would with much stronger stimuli. And those symptoms include things like increased heart rate, muscle tension, pressure in the chest, tension in the arms, in the head, all throughout the body, increased body temperature, physical pain sometimes, shortness of breath, all sorts of different kinds of physiological symptoms associated with nervous system activation. Again, kind of impulsively, immediately in response to those triggers. And then there are behavioral responses. Those behavioral responses often include, again, that immediate sort of impulsive response that is typically aggressive, both verbally or physically, or at least the urge to act in that manner, as well as to carry out avoidance behaviors because the stimulus is so unpleasant that it's natural to want to avoid that sort of unpleasant experience. So oftentimes the individual goes out of their way to avoid coming into contact with that stimulus or the potential to come into contact with that stimulus or things associated with it so that they can avoid the unpleasant experience. And that has significant impact on someone's functioning, whether it's the response itself or whether it's the avoidance behaviors that can really contribute to really impairment in someone's quality of life, as well as potentially to the development of other kinds of emotional problems like depression, for example, or other kinds of anxiety disorders or behavioral disorders such as intermittent explosive disorder or other kinds of behavioral problems like that. So in terms of what these triggers are like, sometimes I'll refer to stimuli or sometimes I'll refer to triggers. We're talking about the same kind of things, what those specific things are that cue these intense responses. So we'll talk about them as triggers most of the time. So the most common triggers are actually vocal sounds, and they're typically related to eating or breathing. So sounds that the mouth makes or the nose makes or the throat makes, such as chewing or slurping or gum smacking, sniffling or sniffing, coughing, breathing, throat clearing, those kinds of sounds can be misophonic triggers. And I know it almost sounds like I read a list of potential vocal tics, right? There is an interesting sort of overlap with the kind of sounds that are commonly serve as stimuli for misophonic reactions when it comes to the human sounds, the vocal sounds that individuals make. Nonverbal sounds or non-human related sounds are typically those that are related to machines, whether they're simple machines like the clicking of a pen or whirring noises of a more complicated machine or the clicking of keyboard tapping of the keys if someone is typing, the sound of a leg bouncing or a rubbing sound or the metallic sound of maybe utensils rubbing against one another as someone is eating, or a rustling sound of paper or tinfoil or saran wrap, for example, the shuffling of feet as someone walks, or the knuckle cracking of someone's joints, for example. All these sorts of nonverbal cues, these other kinds of sounds, are also common misophonic triggers. And the quality of the sound doesn't seem to be related to the intensity of the reaction to it. So it's not like the louder the sound, or the more frequent the sound, or the higher the decibel, the greater the reaction. That's actually not the case. Those qualities of the sound don't appear to be related to the intensity of the reaction to it. Even soft sounds can serve as triggers. You may be related to like ASMR videos, for example, on YouTube, of like quiet chewing sounds, or breathing sounds, or like the smacking of lips, that if you listen closely enough to someone speaking that you can hear, even sounds like that can be misophonic triggers. So the quality of the sound is not necessarily related to the individual's response to it. And so why is that? So right now, the hypothesis is really that there are a range of sounds that can serve as triggers for individuals, and that the triggers are highly individualized to that person's experience, and that it's a learned response specific to that individual, specific to a specific sound itself, and the context in which that sound occurs and is experienced by this individual that elicits the response. So, for example, chewing crunchy items might be a problem if they're experienced at the dinner table with mom, but maybe sitting at the lunch table next to a friend who's chomping down on a bag of chips, that doesn't bother them. So highly specific in terms of the kind of stimulus and the context in which it occurs. So like other kind of sound sensitivities, like I said, the response is not necessarily elicited when the individuals themselves generate the sound. So someone who has a hard time with crunching sounds, for example, might really enjoy eating apples, and that doesn't bother them, not at all. They hear the crunch, it feels a particular way, doesn't bother them at all. But if their younger sibling crunches down on an apple, they have the response. And so typically when they make the sound, it doesn't happen in terms of the response. But when others do it, it does. And actually, some individuals report, and this has been my anecdotal experience too, just as a therapist who treats this at times, that individuals tend to respond more strongly when the sound is generated by someone with whom they're close. So parents are often the individuals who generate those kinds of sounds, for example. And it's not necessarily just sounds, right? Like I'm saying sound because it's, we're often talking about sounds, but the triggers are not necessarily limited to sounds. So for example, seeing a visual cue that's been associated with the sound without the sound itself may also elicit the response. So if someone has a response to, for example, the sound of someone brushing their teeth, the sound of the bristles moving across the teeth, we could show them a video of someone brushing their teeth on mute so that they can't hear the sound and they'll still have the response. So it's interesting that the visuals themselves can potentially be triggering, that not the sounds themselves. Another example is if someone is triggered by the sound of another person chewing something crunchy, for example, that response might actually generalize to being associated with an image, such as seeing a bowl of carrots out on the counter, or a bowl of pretzels out on the table. Some small studies have even shown that misophonic responses can happen to images generated in someone's imagination. So just having someone imagine a bowl of carrots could potentially also result in that same kind of response. And so it's very interesting. There's definitely some associative learning process involved in this problem. And there seems to be an obsessive quality to the process. So there seems to be a hyper focus on the problem and a maintenance of that hyperfocus, like a preoccupation with that particular trigger. So for example, if someone is sitting in math class and they have someone sitting next to them who bounces their leg a lot, they have no ability to pay attention to what the teacher is saying or anything else going on in class or what they're supposed to be doing, because all they can do is think about how this leg bouncing sounds and how unpleasant it is. And they go to great efforts to try to stifle their response to it. So then there's this behavioral response, right? There's this impulsive kind of quality to the immediacy of the response that happens when someone is triggered in this way. And that response, as I mentioned before, is a strong emotional response that prompts unwanted urges to engage in usually externalizing behaviors. So aggressive behaviors like yelling, acting out in some way, throwing things, for example. Any kind of acting out behaviors is typically what people report feeling the urge to do. Whether or not they act on that urge is a different point altogether. Some do and some do not, but they put forth a great deal of effort to try to contain the feeling of the urge, which is very effortful. So the listener typically finds the experience so aversive that they then begin to engage in avoidance behaviors, right? If something feels really unpleasant and you experience really difficult emotions like unwanted anger or anxiety or disgust, or the urge to maybe act out in some way when that's not at all consistent with any kind of pleasant experience that you ever want to have, it makes sense that you would then begin to avoid, right? So avoiding, for example, sitting down at the dinner table with your family will then remove the opportunity for you to be triggered at the dinner table by someone's silverware rubbing against each other, for example, right? It's reinforced through negative reinforcement, right? So not only by not sitting at the dinner table do they remove the opportunity for them to be triggered, but they also learn that avoidance is necessary in order to avoid being triggered, right? So they kind of self-reinforce. It's a self-reinforcing kind of problem. The avoidance begets more avoidance behaviors, and it really begins to negatively impact one's functioning. And I mentioned response inhibition, and I think this is particularly important because those familiar with tic disorders or Tourette's that really understand the idea of response inhibition and how that functions. Response inhibition is that concentrated effort that someone puts forth to suppress one's responses, right? Typically due to perceived social inappropriateness, right? So if you're being triggered in the classroom, for example, by the sound of the teacher writing on the chalkboard, not that there are many classrooms with chalkboards anymore, but I'm sure they probably still exist. It's going to take a whole lot of energy to really try to suppress one's urge to respond to that, whether it's to yell or to run out of the room or to act out in some way. And it takes a lot of mental energy. Those who struggle with these kinds of misophonic reactions also often report a great deal of energy to control their behavioral responses because they know that they're inappropriate and they don't want to have other kinds of problems on top of it, right? So it's bad enough that they're having this unpleasant experience, and they certainly don't need a behavior management concern or some other kind of social problem on top of it. In addition to their intense emotional reaction, right? So they go forth and they put forth a great deal of effort to try to stifle that. And unfortunately, behavioral inhibition, particularly with misophonia, has been associated with feelings of sadness, frustration, self-criticism, and that can further contribute to psychiatric comorbidity, like problems with depression, problems with anxiety, adjustment, other kinds of problems with coping with daily life, because it's really an unpleasant experience to constantly have to self-monitor and avoid. So as I mentioned before, this phenomenon was actually first described in the 90s by an audiologist. It first appeared in the audiology literature. An audiologist by the name of Marcia Johnson described misophonia, although the term wasn't used yet, but she described the phenomenon as a sensitivity to soft sound, or a selective sound sensitivity syndrome. So she saw it as a phenomenon of hearing dysfunction, essentially. But the term misophonia wasn't first actually used until 2001, and it was used as a way to describe the autonomic nervous system arousal symptoms in response to specific sounds. It was described as a problem in which the auditory system was essentially functioning normally, but which was unexpectedly associated with negative behavioral responses, right? So their hearing was working typically, but the response to, right, that hypersensitivity, responsivity to the sound was occurring. And since then, really, all of the work in this area, trying to learn about this phenomenon, has really been trying to differentiate this phenomenon from other kinds of disorders, such as hyperacusis, for example, which is a decreased tolerance to sound, which you see in other kinds of problems, because, and it's different, right? Misophonia is different than hyperacusis because misophonia is a specific sound in a specific context, right? It's not just, I can't tolerate the sound of high-pitched, metallic sounds. It's specifically when my dad cuts his steak with a knife and rubs it between the tines of the fork, right? It's very specific. And also different from phonophobia, which is a fear of sound. And the difference between phonophobia and misophonia is essentially the primary emotion. So the primary emotional response with misophonia is typically irritation or anger, whereas with phonophobia, it's the primary emotional response is essentially anxiety or fear. So although misophonia can co-occur with those other problems, it is considered to be distinctly different from them. And so kind of parsing apart that differentiation when someone presents with this kind of hypersensitivity to sound is really important. So, the question, is it psychiatric or is this auditory? The answer is we really don't know. We don't know yet. There's still so much to learn. But what we do know is that there doesn't seem to be a relationship between misophonia and hearing thresholds. So most individuals with misophonia have normal range hearing. And generally, there's normal auditory sensitivity. They're not particularly sensitive to sounds, right? It's not like hyperacusis. These are very specific sounds with very specific contexts. And the specific nature of individual triggers renders it pretty unlikely to be auditory dysfunction. Again, it's not like anybody who cuts with a knife and fork. It's, dad cutting his steak, for example. It's not the sound of apples crunching as someone eats them. It's when my brother grabs an apple from the fridge and chomps on it in the kitchen when I'm working on my homework, right? So very specific, but we don't know. And there's still a whole lot of work to be done to try to really understand this phenomenon better. I really like this. This is from an NPR story that was broadcast in 2019. If anybody wants to look it up, it's probably still online. It was from a news broadcast on NPR called "When Life's Noises Drive You Mad." And this 18-year-old described her experience of what it's like to hear her family members chewing at the dinner table. And she said, really, it's like my heart starts to pound. I go one of two ways. I either start to cry or I get really intensely angry. It's really intense. I mean, it's like you're going to die. And the individuals that I've seen with misophonia have really similarly very intense reactions that really drives some pretty intense emotional responses: frustration, sadness, depression, lots of avoidance because it feels so bad. So who experiences misophonia? We don't know how many individuals actually experience misophonia. And there are lots of reasons for that. One is it's, of course, a newer phenomenon in general, but we don't have a way to uniformly diagnose misophonia, because again, it's not a formal diagnosis right now because we can't agree on a set of diagnostic criteria. There have been a number of researchers that have offered up some potential clusters of diagnostic criteria, and I'll be showing you some a little bit later on for you to take a look at so that you can get a sense of the kinds of criteria that we're looking at. But yet, we have no agreed upon set of diagnostic criteria for a diagnosis of misophonia. So if you can't diagnose this, it's hard to study it, right? What kind of individuals are you going to include if you can't decide what criteria they have to meet in order to have the disorder and be included in the study? So that's problematic right now, and that limits the ability for us to study and understand the phenomenon. Also, it may be co-occurring with other kinds of problems or be mistaken for other kinds of problems, such as other kinds of psychiatric disorders or auditory phenomenon, right, like that hypersensitivity disorder, or other kinds of hearing threshold problems. It can be confusing, and an accurate understanding of what's going on for the individual is sometimes challenging. And estimates generally vary, but the studies suggest that somewhere around 20% of individuals experience some symptoms of misophonia. I know, like, for example, in our office, when a discussion comes up about misophonia, people always say, oh, I know someone, you know, who has this, or, oh, I think I might have that, right? There's some noise that drives me crazy that my spouse makes, for example, right? It's not uncommon to have these individual sounds that elicit a little bit of annoyance, right? However, we feel like about up to 6% of individuals probably are more likely to have enough symptoms and have those symptoms be impairing enough to their daily lives that it would be considered a disorder. So a much smaller number, but not insignificant. And both men and women tend to report having these experiences. We don't believe there are gender differences in terms of who experiences this phenomenon. And in general, it's considered to be underdiagnosed. It's a kind of problem that lots of people don't understand well and are not aware of. And so we believe that it's underdiagnosed. So oftentimes individuals note that they first experienced this misophonic reaction in childhood or in early adolescence. And I think in the office, you know, we see it most frequently, I would say, in adolescence, in terms of when they come to our attention and come in for help. And many can identify some sort of initial triggering event that can be recalled by the individual, that at the time they can remember eliciting a really strong emotional response, or unpleasant emotions such as disgust, for example. And it can be associated with unpleasant memories. For example, we might have an adult who comes in and is talking about this phenomenon, who says, you know, I remember eating dinner at the family dinner table as a child, and I remember the strong emotional responses to these triggers, such as, you know, family members chewing their food or something like that. But that being said, there have been some small studies that examined the relationship between trauma and misophonia to see if there's an association, and there isn't believed to be an association or any kind of significant relationship anyway between trauma and misophonia. So we don't believe that it is trauma related. Most people report that misophonia has a sudden acute onset. This is not something that slowly develops over time. It's something that all of a sudden they sort of notice that is problematic. And the mean age of diagnosis is 37 years old. So you're saying, wait a minute, but this occurs in early childhood or, you know, early adolescence. Why is it that the age of diagnosis is so much later? This is This is problematic in all sorts of different areas related to psychiatric or neurological phenomenon, unfortunately. It takes a while to get to the right people who know what's going on, and able to make the diagnosis. The problem is considered chronic, but it often goes untreated. So in terms of treatment response, there aren't any treatment studies. We'll talk about that in a little bit. So really what we have is at this time a study of sort of the phenomenon, how do people experience it over time without intervention. And what we see is that over the course of time without treatment, most people experience a worsening of symptoms, whereas some remain stable and fewer experience spontaneous remission of their symptoms. So some research does suggest that there is an increased comorbidity with certain kinds of psychiatric disorders. Those include anxiety disorders, OCD and related disorders, Tourette's disorder, ADHD, depression, and obsessive compulsive personality disorder, with OCD being the most highly co-occurring disorder at about 50%. Now, as far as we know, there is no causal relationship, but you'll see that, and you've probably recognized if you've been to other webinars in the past by NJCTS and you're familiar with the Tourette's literature, you'll recognize these problems all kind of falling in that kind of OC spectrum kind of family, right? These disorders are likely related genetically, right? There's some sort of shared foundational underpinning under these disorders, and misophonia seems to be one of those phenomena as well, which is why we consider it at this point related to obsessive compulsive and related disorders, because it seems to be related in some way, as well as some of the sort of like symptoms that we observe, such as that obsessional quality. But if we look at it in more of a transdiagnostic way, right, we look at the phenomena rather than categorically, right? We look at the, what might be the sort of shared piece that is present in all of these disorders. We think about the possibility that all of these share an over-responsivity to auditory stimuli, that these are sensitive nervous systems, essentially, individuals that have these kinds of disorders, and that over-responsivity is not just a specific stimuli like those auditory triggers, but also other kinds of stimuli that to other individuals who don't have these kinds of disorders might be considered neutral, for example. Sensitive nervous systems, basically. And that's also the case with some other kinds of disorders as well. If you're looking at that over-responsivity to stimuli, that's the case with tinnitus, right? A totally auditory phenomena, that hyperacusis, Tourette's, OCD, anxiety, also autism spectrum disorders, right? Which suggests that there might be, if we look at it in terms of the, a transdiagnostic sort of symptom that could potentially be spread across or describe a lot of different kinds of problems rather than a categorical approach. There might be this shared underlying neuropathology in all of these problems that explain why this particular kind of symptoms, this over-responsivity occurs. So I wanted to show you this just to kind of show you that the process of hearing is complicated. So if you don't remember high school biology class, I'll just refresh your memory a little bit. Audition is complicated. It involves mechanical structures in the ear that receives the vibration of sound, as well as neural structures in the brain that then receive those sound vibrations and send those through pathways of the brain that make meaning of those signals that are being received. So audition, hearing, involves both the ear and the brain. And problems with hearing can involve one or both or the other of those structures. So it's complex. So what exactly then causes this phenomenon? We don't know. It is unclear. But just to kind of cover some things that are considered is, one, there may be some sort of genetic predisposition. And that has been suggested by a number of studies that looked at simply, whether or not people who struggle with misophonia report having family members that also experience this phenomenon. And that is the case. Individuals with misophonia are more likely than others to report having family members that share this kind of experience. But unfortunately, at this point, studies haven't yet demonstrated any kind of familial differences in terms of auditory processes or cognitive processes that are involved in hearing or sensitivity to sound. We just don't know at this point. But it's an interesting sort of potential factor involved in the etiology of misophonia. There's also a hypothesis about the relationship between misophonia and obsessive compulsive disorder or obsessive compulsive personality disorder. So one hypothesis is essentially that someone who is morally strict or less flexible cognitively or psychologically, as is often the case with individuals that have OCD or OCPD, that they would have potentially more difficult time coping with impolite eating sounds, for example. And that would then result in avoidance behaviors because it's difficult to tolerate due to inflexibility. And individuals report that when activated, they're unable to redirect their attention. So there's also this sort of obsessional quality or this hyper focus to the stimulus. So there's sort of an obsessional nature. We don't have any evidence to suggest that this is true, but it is certainly one hypothesis that's been offered. Another hypothesis is that this is a learned response through classical conditioning. So again, thinking back to high school science class, right? You might remember Pavlov and the dogs, right? Classical conditioning is a process that happens when a trigger, like a sound, for example, is paired with a harmful emotional response, right? Something that is really unpleasant or intense, like fear or disgust. And based on this model, a person experiences that trigger in close proximity, for example, to an unpleasant experience, and that unpleasant experience then causes a physiological response, and over time, that sound or that trigger becomes associated with the unpleasant experience, such as the sound alone, and that it's able to directly elicit the physiological response, right? So the more someone experiences these things, the more closely it becomes associated and can then also generalize to other things like images of it or seeing crunchy foods when chewing on potato chips or tacos, for example, was the original triggering sound that really bothered someone. So it can, through learning, generalize to similar sorts of contexts, for example, and then is reinforced by the avoidance behaviors. There's also a theory about heightened interoception. That's the sort of internal sense of someone's internal experiences, their internal sensations, that it's possible that they experience these sensations more intensely than other people, and that therefore they respond more intensely, right? That they may be over-responsive because they are also sensitive to it. Again, we don't have any evidence for it, but it is a theory, and it's one that individuals are studying, that are looking at. There are also hypotheses that there may be alterations in the limbic system, which is the area of the brain that is responsible for emotional processing, and also the autonomic nervous system. Again, like individuals get over-aroused in relation to these specific triggers. So what is happening there in these pathways that is leading to this sort of pattern of responses? And the answer isn't really like A, B, C, D, E. It's probably, you know, a combination of some of these, or maybe even all of the above. We just don't know. So just a word about sensory sensitization theory in misophonia. When a trigger becomes associated with a really significant response, right? In this case, that autonomic nervous system arousal, right? That physiological arousal that happens, as well as that emotional reactivity and that behavioral urge to act out, right? That intense response. It's pretty unpleasant, and your brain naturally says, I need to look out for this trigger because this response is really unpleasant. And so individuals become hypersensitive to or hypervigilant to that trigger, right? They're going to be more aware of it happening in their environment, or they're going to be more heightened to the potential for it happening in their environment, right? That's a biological protective mechanism, right? If there's something that feels threatening because it's a really unpleasant experience, or, you know, we experience it as somewhat dangerous or threatening or really unpleasant, right? It makes sense that we are then going to maybe be a little bit more vigilant to it and its potential for it in our environment, so that we can potentially avoid it because it's so unpleasant. And that's, we call that sensory sensitization. So the more unpleasant it is, the more essentially, the more we experienced it in a heightened way. So as I mentioned, the diagnosis of misophonia is a little tricky because it's not technically a diagnosis. Right now, most of us consider it to be what's termed an other obsessive and compulsive related disorder, because we feel that it shares the most commonality with some disorders in this category, as I mentioned, and that the co-occurrence rate with OCD is pretty high in relation to other kinds of problems. And again, there's that preoccupation with the stimulus that is expressed, and also it involves avoidance behaviors, which happens with OCD as well. So the proposed diagnostic criteria essentially include that there is a hypersensitivity to the presence of, or the anticipation of the presence of, a specific sound or other kind of stimulus, doesn't have to be a sound, right? That is conditioned, that is immediate in terms of response, and like kind of reflexive, and that involves physiological arousal in addition to emotional arousal. That there's then a dysregulation of aggressive emotions, whether it's anger or rage or fear or disgust even, and the associated thoughts, recognizing them as illogical and negative, but also having difficulty controlling them or suppressing them. Also avoidance behaviors, not just of the triggers themselves, but also stimuli associated with specific sounds, right? Like I mentioned, it's not just about, you know, tacos, it's about potentially like avoiding eating out in restaurants because who knows what anybody around you is going to order. Maybe they'll order something crunchy like tacos, and that will be a problem for you. Or never sitting down to eat at the family dinner table anymore because there might be something that's served that triggers you, for example. The individual's sensitivity and their autonomic and emotional experience of it, as well as the avoidance behaviors and other kinds of behavioral responses, must result in significant distress or impairment in the functioning. So it's about the externalizing behaviors such as tantrums or outbursts, and the impact on the individual's function, right? So disruptions to the classroom or to work settings, problems with having limited ability to participate in activities for fear that you might come in contact with that trigger, or that involves specific family accommodation of symptoms. For example, I saw a family once who they never served steak because of the concern about the knife and the fork rubbing together, and they never served tacos because the crunchy of the tacos, specifically with the mom, really bothered the teenage daughter, such that she wouldn't eat at the dinner table if they were served. So the family just didn't eat those things. And the symptoms can't be better explained by another psychiatric disorder. So those are the proposed diagnostic criteria. In terms of assessment, generally speaking, there are some self-report scales, some questionnaires essentially, that are sometimes used to assess the presence of symptoms and the severity of symptoms, although technically the measures that we have are still in development. They don't have really robust psychometrics in terms of reliability and validity, but there are some out there. So, we're starting to be able to develop a little bit of an understanding of how to measure people's experiences of this. So some of those measures include a measure called the Misophonia questionnaire, the Misophonia severity scale. There's one called MisoQuest. There's one called Misophonia response scale. So those kinds of questionnaires are available and are sometimes used by clinicians to assess the experience that someone has. Also, those suspected of having misophonia should also be evaluated by an audiologist and a neurologist to make sure that we rule out any kind of conditions that affect the hearing and or the nervous system that could potentially look like misophonia, but is not misophonia. So hyperacusis, for example, that hypersensitivity to sound, testing the pitch threshold of sound, for example, and sound discomfort levels, all that's really important. In terms of what we do to make sure that we thoroughly understand it is we conduct a thorough clinical interview. That's really important for treatment planning. What we want to know is we want to rule out co-occurring disorders, right? We want to make sure that what we're seeing is what we're seeing, and there isn't something else that might be complicating the diagnosis or the clinical picture in general. We want to understand when the symptoms began, what specifically triggers the response and in what contexts, and what exactly is the response to the trigger and the consequences of the response, as well as any kind of avoidance behaviors or accommodations that individuals in the person's life might be making in order to try to maintain the individual's functioning. So we really want to understand the pattern that's happening. And we look at this in a very sort of behavioral manner because it's what we have in terms of being able to achieve some sort of improvement to someone's functioning. So what we look at is there's this antecedent cue, which is the trigger for the behavior, right? Like a sound, like throat clearing, for example. And then there's this autonomic nervous system response to the behavior, that immediate sort of reflexive response where there's biological that physiological activation, emotional reactivity, and that drive to respond physically, right? That physiological activation that drives the urge to act. And then there are consequences of the behavior, right? The behavior that results in either avoidance or acting out behavior, for example, and that might be the consequences to oneself, like social consequences, emotional consequences, cognitive, like beating oneself up for having these experiences or being frustrated with having these experiences, the physiological consequences, such as the physical symptoms or functional impairment that results, for example. And then there's that behavioral adaptation, right? Like how do I keep functioning even though this is a problem for me? And typically what happens is then people start to avoid and cut things out of their lives and try to change what they come in contact with so that they could potentially avoid these kinds of situations. And these avoidance behaviors, while they do, at least at first, decrease the likelihood that they're going to experience that misophonic reaction, right? Like if you're not at the dinner table, you certainly are probably not going to be triggered by someone's eating because you're not there. But they also carry the consequence of reinforcing more avoidance, right? Like I didn't have to experience that reaction, and so I'm going to keep doing this thing so that I don't have to experience that reaction. And that negative reinforcement keeps the cycle going, as well as limit the person's functioning, right? Like in that example, they don't get to eat dinner with their family. And that further promotes unwanted thoughts, like, feeling like it's their fault the family can't get together and have dinner anymore, for example. Emotional consequences like feeling sad, frustrated. Interpersonal consequences like, having interpersonal conflict with, mom and dad are really frustrated because their teenager doesn't sit and have dinner with them anymore, for example. And the other kinds of consequences associated with the avoidance behaviors. Okay, so lastly, what do we do? It's important to know that there isn't any current evidence-based treatment for misophonia. Not medications, not psychological treatments. There isn't anything that we know is effective. In other words, there haven't been any good randomized controlled trials, and we don't know what happens, prognostically, when we try different treatments right now. Like, we're just not at that point in studying this problem. What we do know is that pharmacological treatments may be indicated for comorbid difficulties, and that might be helpful to them. So if someone has associated depressive symptoms, medication might be helpful for that. And so pharmacology, medication treatment might be a useful piece to the treatment puzzle, to the treatment picture. But there isn't any FDA-approved medication for misophonia. There are some case reports in the literature that kind of one-off demonstrate a case in which an anxiolytic medication, anxiety medication has been helpful, or an antidepressant, or methylphenidate, which is a stimulant like Ritalin, for example, or propranolol, which is a beta blocker, often used for a high blood pressure, for example. But these are one-off case studies. We just don't know what's effective in terms of medications. The current standard of care is psychological treatment, and it's based on also case reports. Again, it's clinical experience at this point, because we don't have any good treatment trials, but it is based on pretty strong foundational kinds of interventions for similar kinds of problems that have really strong evidence behind them. So there is method to the madness of trying this kind of treatment, essentially. The goals of treatment in terms of psychological intervention is to increase distress tolerance, not necessarily desensitize, right? The idea of systematic desensitization, like the more you get accustomed to coming into contact with a particular stimulus, the less it bothers you, that's not necessarily the case. And it's not the goal here either. We call that habituation, right? You get used to it, so it doesn't seem like bothersome anymore. And we don't know whether or not that happens. Our goal really is to increase someone's tolerance of it, because we want to get them back to functioning. So it's reducing emotional and behavioral reactivity, right? To kind of reel that in, give them good skills to be able to better control, better modulate their emotional and behavioral experiences in relation to these triggers, and reduce avoidance behaviors and any kinds of accommodations, right? Because we want them to function fully. We want them to be able to enjoy their lives and not have to avoid things that could potentially spontaneously trigger this response. We want to increase the breadth of their daily functioning, again, to not avoid things for fear that they might be triggered, and building contingency management to reinforce skills we want them to practice, not just in the session, but between sessions, because we want them to get back to their lives and not have their lives limited by the problem. So the kinds of ways that we do that is to do cognitive behavioral therapy, and that involves both cognitive and behavioral strategies that have been used in changing other kinds of problematic patterns like this, reducing distress, improving daily functioning. So in terms of cognitive kinds of interventions, we help individuals to identify the problematic kinds of thinking patterns that they might be engaging in, and help them to change the kinds of thoughts and beliefs that they have about their sound perception and their ability to tolerate sounds. In terms of behavioral therapy, we use exposure therapy essentially because we want to help them to change these kinds of maladaptive patterns so that they're not avoiding. Again, not necessarily habituation. We really kind of focus on what we call an inhibitory learning sort of perspective, in which the extinction of the response depends not only on learning that they're safe, but also that it's okay to experience emotional responses in response to a trigger, right? Like I can't guarantee that you won't feel uncomfortable, but I want you to be able to do this thing and to know that you can tolerate that if you do feel uncomfortable, if that makes any sense. And the therapeutic process involves essentially exposure therapy, repeated exposures, although exposure therapy alone might not always, again, lead to habituation. It's not to eliminate the the discomfort. It's or necessarily to diminish sound sensitivity or any kind of feeling of subjective distress, but really the goal is more inhibitory learning in nature, that they can learn to tolerate their distress and still engage in their lives, even if they have a hard time hearing the sound of crunching. They can still enjoy dinner with their family and not be so preoccupied with the sound of crunching, for example. Lastly, oftentimes we use acceptance and commitment therapy as an adjunct to help individuals become more aware of their experience, right? Because when we're really upset by something, our awareness of our experience tends to really narrow down, right? That preoccupation. We want to help people become more open to and aware of their full experience of all their senses, not just the ones that are problematic for them. We want them to be open and willing to have the full range of experiences, even if they come into contact with something that's unpleasant. So being able to do things because it's important to them, even in the presence of unwanted internal experiences like emotions or physiological arousal, is really the goal. And then dialectical behavioral therapy skills can be really helpful because they focus on helping people to learn how to tolerate distress better and better modulate their emotional experiences, as well as engage in more effective interpersonal interactions and also building their mindfulness skills. All right, that was a lot. It was a lot of information, also a lot of unknowns. I'm sure we have a lot of questions. What questions can I answer?
First and foremost, thank you so much, Dr. Deibler. I know that we're getting close to 8:30. We do have a couple of questions. If you do need to hop off relatively soon, I just want to say thank you so much. That there will be an archive recording of this webinar, and it will be on our website tomorrow at www.njcts.org. In addition, we also have, we also are having an exit survey, which we would really appreciate you filling out. Our webinar blog will be open for the next 7 days with any questions. If you want to post any on our blog, feel free to. Dr. Deibler will be answering it for the next 7 days. And in addition, our next webinar will be on understanding and treating scrupulosity OCD. It'll be on Wednesday, March 15th at 7:30 p.m. So now, here are the questions. And if any of you have questions, feel free to write them in the question box and I'll be able to answer those as well. So my first question for you, Marla, is, so this individual said, starting when my son was 9 and continuing to the present, he is now 32 years old. He cannot hear the sound 10, whether it be just the number or if 10 is used within a word like attention. Would this be considered a form of misophonia?
I would need to know more about it, but chances are no. It actually sounds like a pretty common symptom of OCD. So I would really want to know, is it specific to a person, a context, What would happen if the individual did hear the word 10? Does it lead to, what kind of emotion does it elicit? Are there thoughts or fears associated with what might happen if they hear the word 10? When they do hear the word 10, what is do they have anything that they feel like they need to do in order to neutralize it or change it in some way or correct it in some way, or they're afraid that something might happen? It sounds like probably more likely related to OCD.
Okay, thank you. And another question we have is, this individual said that they have a 19-year-old daughter with autism who was diagnosed with misophonia last year. Her school and the staff at her school will report incidents of disruptive behavior, and most times when the incidents occurred, they state that it was for no reason. How would you suggest talking to the school about this?
So my first question would be, does your child have an IEP? Is there a child study team involved? Because if there is, you have a really great resource available to you. Every school district has a behavior analyst. Sometimes it's every school, not just the district. So what I would ask for is for the behavior analyst to do a consult observation of your child, see if they'll allow that. To do what they call an FBA, or a functional behavior analysis. You basically want the child to be observed in different contexts and hopefully observe the behavior happening. And behavior analysts are really great at taking data on what the potential triggers are, like what the context is, what the consequences are, like why exactly it's occurring, and they give really great recommendations for teachers in the context of the classroom to facilitate interventions.
And then our last question is it possible for misophonia to be associated with a single trigger or the sounds of a single person?
Yes, yes, and yes. It's often that way, actually. It's sort of a funny phenomenon, and it's one of the things that really differentiates it from other kinds of purely auditory phenomenon, right? It's not necessarily the sound of, a pen clicking, for example. It's the sound of that kid who sits next to me in math who clicks his pen all the time, right? It's a very specific kind of stimulus in a very specific context. And yes, often specifically associated with one individual or a small number of individuals, not necessarily across the board. This sound in general in any context from any person.
We have a couple more. Oh, bear with me. Okay. So, okay. So another question we have is, the older I get, the more sounds are driving me crazy. I'm really struggling being in an elementary classroom filled with a variety of noises, and I really don't know how to cope. Any suggestions?
As we age, hearing changes sometimes. And so I think the first thing to do really is to rule out any changes in your actual hearing abilities. It's possible that, for example, you're having a harder time with certain range of sounds, and so others are becoming more problematic for you. So I would, first I would actually consult with an audiologist and have some tests done to make sure that you rule out any possible problems with hearing that might be contributing to your what you notice, essentially. And if they rule out the underlying potential for medical reasons, then it is something that you could potentially treat from a psychological sort of perspective, right, in the ways that we talked about it.
Just saw for the first question that I had asked, that was the person said that they were like, I should have made it clear that I am the teacher.
I figured that. Yeah.
I think they were talking about a student. They just want to make sure.
Yeah.
Okay, so another question
That
is,
also leads me to think, like, are there associations with, having a long career as a teacher in a classroom that are also kind of contributing to your irritation with the sounds, right? Like, I think sometimes our experiences change over time and contribute to our overall, sense of satisfaction in those settings as well.
oh yeah, no, definitely, definitely. Okay, so we do have one more question. It says, my 14-year-old daughter has been wearing iPod iPods at dinner. I guess she means the headphones
Mhm.
at dinner to drown out chewing noises our family makes. Should we be allowing this as a way for her to sit at the dinner table?
That's a great question. I think it depends on your child, right? Like, if your child has um, a problem with sensitivity to sound, like an auditory problem, then that might be an acceptable accommodation to make. Um, or if the child has a complicating disorder such as autism, for example, where they become overstimulated in a very different way than misophonia, then that might also be a totally acceptable accommodation to make. But if it really is just they're annoyed with the sound, it's worth exploring removing to, and perhaps in a graded manner, not necessarily saying no more earpods at the table. It might really be, a way to sort of like slowly do that by maybe decreasing the volume first, maybe removing one, then maybe the other, for example, like successive approximations to it, to get the child to be at the table, right? Because we're just thinking functionally, right? Like, we should all be able to sit at a dinner table with other people and engage in conversation and be interactive, right? It's a good adaptive thing to be able to do. And teenagers have all sorts of reasons for wanting to wear their headphones at the table. I can attest to that as a parent of 3 teenagers. So maybe it's sensitivity to sound, or maybe it's just I want to listen to my YouTube show or whatever, you know.
And then I totally lied. I have one more question. I accidentally skipped over it. So another person said, do you see eating disorders happen with those who do not like hearing themselves eat?
That's a great question.
Right.
Personally, clinically, no, because I don't see eating disorders. So I don't see that. Have I seen that in misophonia? I don't think so. But it might also be because I don't see eating disorders. It's just outside my area of expertise, so I don't treat it. I really treat OC spectrum stuff, exclusive of eating disorders. So it's a good question, though. I would think no. My guess would be no, because generally speaking, when people experience misophonia, they're the sounds of other people and not themselves. But it's just a guess.
Thank you so, so much, Marla, for staying on a little bit after to be able to answer questions. And thank you so, so much to everyone that was able to stay on a little bit after to be here for the Q&A. So just super quick, I know I touched upon this earlier, but an archive recording of tonight's webinar will be posted on our website at www.njcts.org under programs. Any questions that we were not able to get to tonight will be posted under the archive webinar in the webinar blog. The blog will be open and available for the next 7 days. If you have any questions for our presenter, feel free to post on the blog as often as you would like. As you close out of the webinar, there is an exit survey which we need everyone attending to fill out. Our next presentation, Understanding and Treating Scrupulosity, OCD, presented by Mr. Ferd Palumbo, is scheduled for Wednesday, March 15th at 7:30 p.m. Eastern Standard Time. This ends tonight's webinar. Thank you again so, so much, Dr. Deibler, for your presentation, and thank you everyone for attending tonight. We hope that you have a wonderful night.